Good day and welcome to this presentation. My name is Robert Maritz and I'm a histopathologist with Ampath Laboratories, based at the Cedar Road Lab in Fourways, Johannesburg. I'm going to present three interesting cases of metastatic lobular carcinoma, followed by a brief discussion of the challenges associated with making this sometimes difficult diagnosis. The first case is that of a 56-year-old female who underwent cholecystectomy. We received a surgically incised gallbladder. Of note, the wall was thickened and no gallstones were identified. This is a medium power view of the gallbladder demonstrating features of chronic cholecystitis, including Rokitansky-Ashov sinus formation and mild muscular hypertrophy. At high power, one can see a lymphocytic inflammatory cell infiltrate within the lamina propria, consistent with chronic cholecystitis. Again at medium power, a subtle infiltrate is present within and extending beyond the muscularis propria into the subserosa of the gallbladder. At this power, the infiltrate has the appearance of inflammatory cells. At high power, the cells comprising the infiltrate are seen to have relatively large nuclei, larger than the surrounding lymphocytes. Given the bland nuclear morphology, one could consider the possibility of histiocytes. When one really scrutinizes the cells in question, however, it becomes apparent that there is a mild to focally moderate degree of nuclear pleomorphism, with at least some cells containing prominent nucleoli. Furthermore, some cells are seen to display a so-called signet ring appearance, with the cells containing large cytoplasmic vacuoles, causing displacement of the nuclei to the periphery. The aforementioned cytological features prompted a panel of immunohistochemical stains. A CD68 stain does highlight occasional histiocytes, but is negative in the larger atypical cells. An AE1, AE3 stain, which stains epithelial cells, is positive, as one can see on the right-hand side of the picture. This is a high-power view demonstrating the strong AE1, AE3 positivity. The cytokeratin 7 stain is also strongly positive. This stains carcinomas of lung, upper gastrointestinal tract, breast, female genital tract, and thyroid origin, as well as mesothelial cells and mesotheliomas. The cytokeratin 20 stain is negative, militating against a carcinoma of colorectal origin. The CDX2 stain, which is a marker of intestinal differentiation, is also negative, again making a metastatic carcinoma of gastrointestinal tract origin unlikely. The estrogen receptor stain, which is a marker of tumors of mammary and female genital tract origin, demonstrates strong nuclear positivity in the atypical cells. The E-cadherin stain, which is lost in lobular carcinomas, is completely negative. This brings us to the final diagnosis, that of a metastatic adenocarcinoma, favored to represent a metastatic lobular carcinoma of the breast. The surgeon who performed the cholecystectomy indicated that the patient had no known history of malignancy. The patient was unfortunately lost to follow-up, and we have no indication whether or not she was diagnosed with a primary mammary carcinoma following this diagnosis. This brings us to the second case. This is the case of a 68-year-old lady who underwent a rectal biopsy. We received two fragments of tissue. The first represents normal rectal mucosa, apart from some mild procedure-related hemorrhage visible at the top left of the image. The second fragment of tissue showed expansion of the lamina propria by a disc-cohesive population of cells. At this power, one can appreciate the absence of gland or nest formation by these cells. At high power, one can see a population of large tumor cells displaying similar features to those seen in the previous case, perhaps with a greater degree of nuclear pleomorphism. The main differential diagnostic consideration in this case is that of a primary colorectal signet ring type carcinoma. Immunohistochemistry, however, excluded this diagnosis, given the negativity with the cytokeratin 20 and CDX2 stains. The cytokeratin 7 stain, together with GATA3, a marker of tumors of breast and urothelial origin, were both positive. Again, the E-cadherin stain showed loss of staining within the lesional cells. The final diagnosis, therefore, was not that of a colorectal signet ring cell carcinoma, but rather a metastatic lobular carcinoma of the breast. At the time of the biopsy, we were provided with the history that the patient was known with lobular carcinoma. This takes us to the final case. The 60-year-old lady presented with ascites. Acidic fluid was submitted for cytology. We received blood-stained fluid. The resulting smears showed dense neutrophilic inflammation. Isolated larger cells were present, interpreted as histiocytes. This case was sent out as showing dense inflammation with no malignant cells identified. Fortunately, we also received a small blood clot, which was to be processed for histology. The following day, we received the sections prepared from the blood clot. Again, one can appreciate that dense neutrophilic inflammation is present. In these sections, however, one can also see very occasional large, mildly pleomorphic cells with eccentric nuclei and amphiphilic cytoplasm. The presence of these atypical cells prompted a call to the submitting clinician, who confirmed that the patient was known with lobular carcinoma of the breast and had presented with widespread metastatic disease. Immunohistochemistry was performed on the blood clot. The AE1, AE3, and estrogen receptor stains were positive in the atypical cells, and the calretinin stain was negative, excluding reactive mesothelial cells. The final amended diagnosis was, therefore, that of a very limited peritoneal fluid involvement by metastatic lobular carcinoma, an extremely scary case from a pathologist's point of view for sure. In terms of possible sites to which lobular carcinomas metastasize, lymph nodes are the most common, followed by bone and gastrointestinal tract. Other sites include female genital tract, meninges, and the pleural and peritoneal cavities. Metastases to the gallbladder are extremely rare, especially as an initial presentation, as was the case with the first patient. As we have seen, lobular carcinoma metastases can be extremely subtle and may easily be overlooked. The first challenge is to determine that a tumor is present and not dismiss the cells as mere inflammation. The differential diagnosis then includes mammary carcinomas of no special type with a lobular morphology, poorly cohesive carcinomas of gastrointestinal tract origin, hematolymphoid neoplasms such as plasma cell dyscrasias, lymphomas, and granulocytic sarcomas, and very rarely sclerosing epithelioid sarcomas. The take-home messages from this talk are that metastases from lobular carcinoma can be extremely subtle. One must have a low threshold for the use of immunohistochemistry, and the importance of a good clinical history cannot be overstated. Just a friendly reminder that, by using the Ampath mobile app, one can receive their patient results in real time. The app is available from the Apple and Android app stores. Please chat to your Ampath marketer for further information. Thank you for taking the time to listen to this presentation. I hope you enjoyed it and found it useful.